My assessment is on the Beck's Anxiety Inventory, authored by Aaron T. Beck and Robert E. Steer, published by the Psychological Corporation in 1993 with a copyright of 1990 and 1987. The assessment was designed for adult psychiatric outpatients, although a few adolescents were also included in the study or in the sample. The purpose, the BAI intends to assess the symptoms and severity of anxiety in adults and adolescents. Some administration considerations. The BAI must be administered by paraprofessionals who have at least a level B administration qualification. What that means basically is that a master's level degree in an accredited program is the minimum requirement. Then that usually accompanied with that is programs such as the course that we're taking in assessments, as well as some clinical supervision education in being able to administer these assessments effectively. As far as the test makeup, it's quite simple. It consists of 21 test items, and each item is rated according to the client's perception of the severity as it pertains to him or her. Specifically, we can go through these. There's 0 would be not at all, 1 would be reported as mildly, 2 would be reported as moderately, and 3 would be reported as severely. Once a client has gone through and calculate and chosen the specific severity for each item, the test administrator will go through and tabulate and add all the scores up together to come out with an overall score. According to the test manual, these can be rated according to scores of 0 to 7 are rated as minimal, 8 to 15 are considered mild, 16 to 25 are moderate, and 26 to 63 are considered severe. Now, the length of the time to administer this is actually quite short, between 5 to 10 minutes. And the quick turnaround allows for processing of the results within the immediate counseling session. So this can be quite a good benefit for those clients who come in. Let's say they're suffering from immediate physical manifestations of anxiety, and the counselor can say, let's do this assessment. It's going to take a few minutes. We'll go through it, and then we'll talk about it. And as we've learned through our assessment class, it's important to talk about how the client feels about that, what is related to the constructs, is how they relate to the client's presenting concerns, and so forth. So we can go through and say, hey, how did you feel about taking that? Are these relevant for what you're going through? If so, how? And helping the client to explore some of the meaning associated with that, as well as presenting some kind of collaborative interventions that can help possibly remediate or mediate some of those symptoms right away, as well as some longer-term interventions that will help reduce anxiety over the long term. Another benefit of this is that this test can be re-administered quickly. Let's say the same client comes back in a week later, and we want to evaluate how those manifestations have changed, if they have. And if not, what can we do to try to get to those reduction in symptomologies? If some of the interventions are working, if they're not working, so forth. So it allows for a collaborative process to discuss those symptoms in a way that benefits the client, and it's fairly quickly easy to do. And also the cost is quite reasonable. The cost is approximately only $5 per administration per client, so it shouldn't impede upon a client's SES or ability to pay. Let's move on to some validity considerations in this test. There were 5 considered in the test manual, starting with the content. The test items were originally drawn from the BAI. They were originally drawn from other anxiety assessments, such as the anxiety checklist, the PDR checklist, and the situation checklist. The items also corresponded to criteria presented in the DSM-3 for anxiety disorder, specifically those for panic disorder and general anxiety disorder. Moving on to concurrent validity, Beck and his colleagues in 1988 found that his patients' BAI scores correlated with the Hamilton Anxiety Rating at a 0.51. The patients also took other assessments, of the cognition checklist, and that had a high 0.51 correlation, or significant, I should say. And they also, the research shows, also found that the BAI scores coordinated or correlated with the trait and state subscales of the state trait anxiety inventory. Moving on to construct validity. The BAI intends to differentiate between anxiety and depression, whereas many other anxiety inventories include depression. Now, this is important because, as we know as clinicians, a lot of our clients are going to come in with comorbidity symptoms of anxiety, depression, whatever. And so what Beck wanted to do, and his colleagues, we wanted to say, well, look, we can measure anxiety specifically that's teased apart from depression in order to try to just deal with anxiety and not depression. So what they did, they correlated some of their findings with, let's say, the Hamilton Psychiatric Rating Scale for depression. It had a correlation of 0.25. The BAI and the BDI were correlated at a 0.48, and the BAI with depression subscale of the CCL was 0.22. Moving on to discriminant validity. There was found to be a moderate overlap between BAI scores of a group with primary anxiety disorder and no depression, and another group of patients with a primary depression disorder and no anxiety. Now, again, this is similar to the previous construct where we talked about trying to tease apart the two types of anxiety versus depression. But this does demonstrate there was only a moderate overlap versus there was an extreme overlap. That would indicate that there was no discernment between discriminating one measure versus another. Moving on to factorial validity. There were two broad categories that were teased out, including the somatic aspects and subjective and panic-related aspects. And these two were co-related with each other and found to be significant. Also, from these two main categories, 4 additional clusters of neurophysiological, subjective, panic, and autonomic symptoms were found, and they too were all found to have high correlations between them. Now let's talk a little bit about reliability considerations. The authors found that there was a high internal consistency reliability of 0.92, and that there was also a high test-retest reliability. Beck and his colleagues found from their population that they administered the test 1 week later, and those same clients reported having similar results as the first administration, with a correlation of 0.75. Now let's talk about norming considerations. Beck and his colleagues in 1988, what they did is they drew 3 successive samples of outpatient psychiatric outpatients, which include 456 men and 630 women. Out of this total population, they chose 160 sample size that was studied extensively for the validity and reliability analysis that we just discussed. Now, as far as appropriateness for this test for specialized populations, Friedrich and his colleagues in 92 found 393 patients to have their gender and age significantly related to their overall anxiety scores. In general, what they found is that women described more severe self-reported anxiety than men, and that younger outpatients reported more severe levels of anxiety over the older populations. Now, unfortunately, the authors did not present enough information regarding culture, SES, or other variables related to their populations. These gaps in the literature are actually opportunities for us as social scientists to further investigate and either validate or refute the findings that Beck and his colleagues originally found. According to Hayes in 1996, she conceptualized some of these factors that could be contributing to somebody's overall social makeup, and those considerations can be teased apart, that we might find one group might actually be affected more by anxiety than another. For example, we go through the addressing model, as Hayes purports, there's differences in like age, disease, religion, sexuality, those sort of things. All of those can be teased apart and looked upon as potential research studies. Also, there's other limitations. Anxiety features that include cognitive, affective, and behavioral components might actually be de-emphasized with the BAI, because the BAI seems to consider a lot of physiological functioning, but not necessarily thought processing, such as in disorders like OCD or social phobia. Also, we need to consider Better understanding of anxiety that's teased apart from adults and adolescents and children. Myers and his colleagues in 2001, they attempted to norm data for children with the Penn State Worry Questionnaire that measured excessive, generalized, and uncontrollable worry. So basically, supplemental research is needed further to evaluate these main groups and to tease them apart into ages, cultural considerations, etc. Thank you.